I Die New Mexico Festival panel discussion about hospice. I'm Gail Rubin, the Doyenne of Death, and welcome to everyone here in the room at French Funerals and Cremations, Rio Rancho location. Beautiful view of Sandia Mountain out to the east, and we have a great slate of programs or speakers for you this afternoon. Today, and before we get started, I do want to give a shout out thanks to French Funerals and Cremations and Sunset Memorial Park and Passages International and Keeper for helping us make these festival events possible. So, to get started with this session about hospice, our theme today is Discussing Death Won't Kill You. And we have not, in the 6 years I've been doing these Before I Die festivals, had a session about hospice. So I am thrilled that we have all of these ladies, and notice it's all ladies. We should talk about this. To talk about what hospice is, how you take advantage of it. I would definitely like to touch on the medical aid in dying aspect of being here in New Mexico. And the way we're going to get started is our panelists will all introduce themselves and the hospices that they are with. So let's start.
My name is Kim Montgomery. I'm a hospice social worker, and I work with Bosque Trails Hospice.
Okay. Yeah.
My name is Anna Christensen. I am a social worker with Gentiva Hospice, and later Michelle, the director, will join me.
Wonderful.
My name is Katie Martin. I'm the director of High Desert Hospice.
My name is Jude Quintana, and I'm with Presbyterian. I'm their volunteer manager.
Hello, my name is Zandra, and I'm a patient care manager for Presbyterian Hospice. So nice to meet you all.
So let's throw this open with the question, what's the biggest misconception people have of hospice?
That morphine will kill their loved one.
And that's not, well, I mean, expand, please.
So lots of people, when they're looking or discussing hospice care, one of the things they always bring up is, you know, how much morphine do you use? Will it kill my mom? Will she become an addict? Will she become addicted to it? So there's a lot of misunderstandings on how morphine is used for pain, control, comfort for someone who's at the end of their life.
Mm-hmm. A lot, and just bouncing off of that, you know, we use it for shortness of breath. There's a huge hesitancy of the family members wanting to give it, because when somebody is in the active stages, the chances of them passing away after a dose of morphine are high, but it's not because of the morphine, it's because that's where their body is at. And I think it's a big responsibility, something that my family personally struggled with my grandpa in Las Cruces is, you know, nobody wanted to be the one to give the medication because they felt, you know, if they gave that dose and he passed afterwards, it was going to be their fault. So it's a big responsibility on the family, and there's definitely a huge correlation of hesitation related to it as well.
You guys want to add anything on misconceptions?
I think one of them that I've often heard is, let's not mention the word hospice and let's not talk about death. Because that in itself it's believed that may hasten the process and that one may just give up.
I think a lot of people look at it as, you know, they're throwing in the towel, and it's really the opposite of that. It's a time to really take that experience and focus on yourself, focus on your family, get everybody together, make it the best possible experience that it can be, you know, talk about things that you haven't talked about, have those difficult conversations that, you know, have needed to happen for a while, bridge those family relationships that have maybe been a little strained. And the wonderful thing about hospice is that you have a whole team behind you that can help with those things, that can help with those difficult conversations. You know, my social workers and my chaplains are my lifeblood and my nurses, but I will tell you, my chaplains and social workers really go in there and, you know, bust through the doors of those difficult conversations and say, hey, look, you know, this is where we're at right now. It's terrible that we're here, but we're going to make the best of it moving forward and make it the best experience that it can be.
Can I say something to that?
Yeah.
So being Native New Mexican and Hispanic and Catholic, so that hospice word never came up. We never talked about it at our table. And personally, when it came up and was offered for my brother, we just went into denial. So I feel like the community here in New Mexico, we're just not informed. We're afraid to be informed, and we're afraid to be educated on it. And so understanding that it's a benefit and a choice for your loved one to die comfortably is really important. And that's something that I personally focus on, and so is Presbyterian.
Well, and yeah, I probably should have started with that. What is hospice and how do you get qualified for it?
Yeah.
I had another comment. It's kind of related to what the two of you ladies were saying, but from our providers, even in the hospitals, our oncology groups, that there seems to be a delay in referring patients to hospice. It's like, let's try this, let's try this, let's try that. And it is almost the misconception that we're saving that till the point where we're going to give up. And so that kind of prevents us in hospice from being able to do all the positive, wonderful work that we can do and have enough time to do that teaching, that education, and just like you said, including all of the team members to really meet the needs of patients and help them to preserve their dignity.
Yeah, hospice really makes an incredible impact, and you know, it's hard to cram all of the things that we want that family to experience in 3 days. You know, we have patients that sometimes are on for a matter of hours after we get them out of the hospital. And it's, you know, it's difficult because from our standpoint and where our hearts are at working in hospice is we want everybody to have that experience. We want everybody to be able to know what the benefit is. And hospice is probably the most underutilized Medicare benefit of everything that's offered, because you said nobody wants to have the discussion. We're throwing in the towel if we bring hospice in, and we're just not going to go there. And it's detrimental sometimes.
So it's a diagnosis of
6 months or less is the qualifying. You know, that ranges from, they mentioned oncology, you know, cardiac issues, pulmonary problems, you know, kind of failure to thrive, malnutrition, you know, looking at the patient as a whole, what their comorbidities are. A lot of people do correlate, you know, hospice and cancer patients because that's, you know, one of the most common diagnoses, but chronic cardiac conditions, you know, congestive heart failure, all of those things, your physician will make a referral and say, you know, we're kind of looking at, we've got 6 months or less. And, you know, like we said, coming out of the hospitals, it's a lot less than that, unfortunately. And there is a huge push, especially in, you know, the oncology setting, is to, we've got to continue treatment. You know, there's options, there's this, that, and the other thing that we can try. And at what point, you know, are we looking in quality versus quantity? And that's what I tell everybody. What do you want your quality to be? You can buy time, but if you're, you know, bedbound and sick and miserable, what good is that? I'd rather have 2 really wonderful weeks full of as much joy as they can have given the circumstances than, you know, a month worth of miserable activity and then that's it.
I know the chemo can be so brutal that, you know, it's almost worse than the disease. Yeah.
So you asked the question about what makes somebody eligible for hospice, and there's things called local determination. So they're kind of guidelines that say if you're looking at the disease of heart failure, then they're expecting certain things to be happening. Your ejection fraction, or your breathing, or low response to medicine. And so for each of maybe 7 diagnoses, there's a list of criteria. So what happens first is a primary doctor or specialist refers the patient to the hospice. Then the medical director of the hospice has to say, okay, I agree, this person is eligible for hospice. And then without getting into all the nitty gritties, then what we decide is what level of care is this patient appropriate for? So are they appropriate for home hospice, where the patient, whatever place they call home is the place they get hospice? Or do we have this patient qualify for what we call, it's called GIP, or general inpatient hospice? So we have an inpatient unit at Caseman Hospital that is primarily set up for those hospice patients, like you mentioned, that are maybe coming from the hospital or the community that have significant symptoms that can't be managed in the home setting. And then the other option that we have for our hospice is we have a hospice house that's fairly brand new, and that's a place where people can come in for what we call respite. So their caregiver, the family is going on a vacation, or the caregiver is really exhausted and they need a break. And I know you guys provide respite in other settings, but we have that facility available for them for respite. And so it's up to the team, just like what you mentioned, there's an interdisciplinary team and the provider, and we all decide what's the best place for this person to be. And like one example is we had a patient that was living in California. He was homeless, but he's actually from a pueblo here. And so we decided to bring him home to New Mexico to die. And he was able to stay in the hospice house. And because it's funded by our foundation and all the work that our volunteers do to earn money. And so we were able to provide that care for him for free. And he was able to be close to his Pueblo families. But it's, you know, then it's after what you said is correct. And then it's finding out what level of care we're going to provide hospice.
I think people don't realize maybe for at-home hospice, the amount of involvement that the family or the loved ones or the family of choice, whatever, needs to do to support that patient. Yeah.
And the wonderful thing is that Press does have the inpatient unit, but then the caveat to that is everybody thinks they qualify for the inpatient unit. Everybody wants to go there. And like she said, you know, there is specific criteria that is required to be in the inpatient unit. But really being able to, the biggest thing that we do is education. So not just for the patient, but for their family members. It's a huge responsibility if mom is coming home from the hospital and had a major event, and prior to the hospital stay, she was up walking. She was, you know, able to do her activities of daily living. She was pretty much, you know, independent for the most part, to then maybe she had a heart attack or something like that, and she's coming home now very, very sick, bedbound. How do we care for her? And so that's a big part of our job as hospice, is going in there, wrapping our arms around that whole family, not just the patient, and saying, this is what you need to do. We provide education, we provide durable medical equipment, we provide incontinence supplies, we give the family all of the tools that are required in order to be able to appropriately care for that family and patient in their home. Medication management, a lot of education on that part as well.
And we have another panelist who has joined us. Hi.
Hi there.
Can you tell us your name and your title?
My name is Michelle. I'm the branch administrator for Gentiva Hospice, the Albuquerque location.
Wonderful. So we've been talking, you know, hospice nitty gritty. And we've been talking about inpatient versus at home. Are there any other options besides?
Hospice provides 4 levels of care. There's GIP, which is the inpatient level. There's routine home care, which is kind of the typical level of care that you see, where we provide care in the home wherever the patient lives, facility-based, those types of things. Then there's respite care, and that is a 5-day stay in a facility to help relieve caregiver burnout. And then the final level of care is continuous home care. And this occurs at the patient bedside if there is a crisis.
So that's sort of, rather than putting the person into an inpatient setting,
Correct.
it's a higher level
Yes.
in the home.
Yes.
Okay.
And typically there is a number of hours that have to be met by the hospice team at the bedside by an RN. And then there is, that can be supplemented by a home health aide or another discipline. And that occurs during a crisis of any sort.
And boy, we know about crises when people are on hospice. So we've heard about a team.
Mhm.
Who wants to talk about the team? What kind of roles are on these teams for hospice?
So there's an RN case manager, there's a certified nursing assistant, a chaplain, and a social worker. Those visits vary for frequency depending on the patient's needs and the needs of the family. Your nurse goes in there for medication management, symptom management, doing a head-to-toe assessment, making sure that there's not any issues, skin breakdown. Those are the things that they're kind of keeping an eye on. The certified nursing assistant is there to provide assistance with ADLs, showering, whether it's in the shower, bed bath, changing the linens, kind of getting that patient up and ready for the day, getting them dressed, getting them shaved, the whole thing, making sure that they're nice and clean and presentable and ready for their day. The chaplain and the social worker, they are there for spiritual and psychosocial support. They assist with funeral planning, they assist with family crises, if there's, issues from a psychiatric standpoint of, we're having suicidal ideation, those kind of things. They're there to step in and support in that way. And the chaplain is the spiritual care for the family, whether that's they're agnostic and they just kind of want somebody to be there with them, or they're Catholic and they need somebody to help them get a priest out for last rites. It really just depends on what the needs of the family are.
And one discipline.
Yes,
Yes.
yes.
One discipline
Plus,
is what I do in my job are the volunteers, and often they kind of get
yes,
forgotten.
I'm so sorry.
And we're with Presbyterian and for all of us here, we provide volunteers in the home. And
Mhm.
so they're trained about, dying process, disease process, anticipatory grief. So they have a pretty intense training to be able to be in the homes. And their two primary roles usually are companion. So if someone's alone and they want somebody, the patient wants somebody to be with them for playing games or reading to them. The other role is for caregiver respite. So they may go in, 2 to 4 hours so that the caregiver can, run errands or go to doctor's appointments. With Presbyterian, we have volunteers in our inpatient unit, and they can help directly with our nurses that are doing the care in that unit. Right now in our hospice, we have volunteers there as well. They're helping with companionship. We have music, we have harpists, we have comfort touch. So those are the roles that our volunteers have. And also they help with bereavement. So they're making calls, they're inviting them to memorials, they're sending them literature. And then we have administrative volunteers. So that's my role, that's my discipline.
Yeah.
And the other provider is our providers. We have physicians that our doctors go to patients' homes to see them, to make sure that they do their own assessment. They do something called a face-to-face when a patient is on hospice for a period of time and needs to be recertified. But they basically write the orders and give the medical direction for the nurses. The nurses, just like what you said, are the eyes and ears of the providers, but then it's the provider who actually finally does those final decisions.
And you had said administrative volunteers.
Mhm.
What would that
So-
involve?
They can make booklets in the office. I'm very fortunate because in our program, we have 2 volunteers that are very seasoned and well-trained and professionally retired. I find that a lot with our Presbyterian volunteers. They're professional retirees. And so one is a timekeeper. So what she does is she processes all the timesheets from all the volunteers and calculates those hours because Medicare requires 5% of volunteer hours of the paid care hours. And so we have to meet that 5% throughout the year. Another volunteer maintains their personnel file, so that's confidential information, their driver's license, their social security number, things like that. So those are administrative support. We also have a husband and wife who are working on our training manual and updating that. So those are the administrative support that we really need.
There's a lot of
Mhm,
paperwork in
mhm.
the
Yes,
back end of
yes.
hospice.
Yeah.
It's a lot.
The other thing that we have is a team of quality experts, and those portion of our department for hospice is making sure that we follow the qualifications of what necessary running, following the regulations. CMS has some things called conditions of participation. And so this department makes sure that we maintain the integrity of the care that we're providing, does chart audits, and helps us through surveys to make sure that when the state or the Department of Health come, CMS Joint Commission come, that we're following the regulations that they set out for us. So we have a pretty robust team. We want to make sure that the quality of care that we provide with all these people going out into homes is maintained, and that we're continuing to improve what we're doing.
And did you want?
Yeah, if you don't mind if I add. I like talking about the team, just because I think, being a social worker like Kim and I are, it's really awesome to get in there. And first and foremost is providing, that support to the family during this really difficult time. But it's interesting when families ask me, can maybe they've asked you too, but they'll just say, what does a social worker do? And so what I usually like to tell them is, you've got your nurse and the CNA for the medical side of things, the chaplain for the spiritual side of things, and then us as social workers, we take care of everything else. So it's such a broad range, but it really is, again, number one, showing that support and providing that support. And for 2 is just any resources that you can even think of. We are definitely there and have those tools, and even for helping them build up coping skills and getting them in the respite that the caregivers I see need the most for providing that support.
What else would you say about social workers?
Well, there are things, I've been doing this since 2010, and there are still things, requests I get that I've never received before. So it's just such a broad range, like she mentioned, of so many different things.
You learn new things every day working in a hospice. There will be new situations that you run into that you really haven't seen before. In the past year, we've had like a couple of really unique diagnoses that we've never, had to treat before. So it's always a learning process. There's always new things to learn. There's always new ways to accomplish your goals. There's new literature. I know that you mentioned bereavement. The Medicare regulations are that we follow our families for 13 months after a patient passes. And so there is a lot of documentation that gets sent out in the mail on, coping resources. We have a support group. We have 2. We have one for just normal grief support that is open to the entire community, not just people who have gone through our hospice program. And then we also have our medical aid and dying support group. So it's a lot of care during the passing, but also a significant amount of work after the patient is no longer with us.
So this is a Medicare benefit. Do you have to be older than 65 to access hospice?
No. No, so as long as you're contracted with the insurance, it's the same as any regular doctor's office. You have to go through the contracting process with all of the insurance providers. So, you know, Presbyterian, Blue Cross Blue Shield, United Healthcare, all of the managed care Medicaid, so Western Skies. I'm probably forgetting a couple, but the criteria remains the same, that you do have to have a life expectancy of 6 months or less, but age is not necessarily a factor in that.
And if you don't have a payer, you can be looked at by the particular hospice group to come on unfunded. And the hospice would still provide all the care, all the benefits at no cost to a patient or family that can afford it and does not have insurance.
Correct. And there's also VA.
Oh,
Yes.
yes.
Working with our veterans, there's,
Oh, yeah.
yeah, that's a really big piece of it, is working closely with the Veterans Administration
Yeah.
to help support our veterans.
Because a lot of them don't have Medicare because they are so connected with the VA.
Right, they get
TRICARE. We have
TRICARE, yeah. So working closely with them, in order to facilitate the referral. The VA is an incredible organization, and I always encourage people to utilize that benefit because they offer so much when it comes to this portion of a patient's life. They have a ton of resources, and getting established prior to when you need those is incredibly important.
So I'm a wife of a veteran, and we do have TRICARE, but TRICARE is owned by Medicare. So the funding is there, and we too, I think all of us work with our veterans. What we're facing now is that a lot of our admissions are veterans from Vietnam, because our World War II are kind of dying out. And so the veterans that come from Vietnam are very, very complicated and have complex diagnoses and other conditions. So we have to keep up with the education, the treatment, how we're going to deal with them and give them really good quality of care as well.
Does the VA have inpatient hospice?
They have a comfort wing. They have a comfort wing. They also have the Fisher House. So, you know, they probably work with all of us so that we can take care of our veterans in their homes or, you know, in far distance rural areas. But they work closely for the care of their veterans, and of course the comfort wing and the Fisher House.
Yeah, that palliative care floor that they have over there is really awesome. And they also do something really cool. It's a 6-month end of life contract. So whether that's in a VA foster home, which is a residential home setting that is run by normally whoever lives in that house, they provide the 24/7 care to the veterans in that setting. And then they'll also do an end of life contract with one of the skilled nursing homes here, and they pay 100% of the veterans room and board for that facility. And when that contract is executed, they all usually are admitted to hospice as well. So there's a lot of really amazing benefits out there.
And actually, to add to that too, I know with the 6-month contract, you can still be on hospice if they need to be in a facility. So if you know, if they already know ahead of time, okay, they're going to be at such and such place and they're on hospice services, they can still have that. Because I know the VA and hospice are 2 different entities, but they still work together.
Hospice also, Gentiva runs a We Honor Veterans program. And so we're rated on levels, and you have to meet certain criteria that's set out in order to be eligible for the different levels. So there's 1 through 5. And it's really working with the VA and following specific guidelines to be able to reach those tiers of care. Just our veterans really do have they take a big piece of our hospice care and what we provide, and we really pride ourselves in care of the veterans and working with the VA.
There's a question.
Yes, you've heard the word levels several times. What are the 5 levels?
So they're just numbered, level 1, 2, 3, 4, and 5. in order to get to the next level, the hospice has to engage in specific educations for their staff. We have to be in talks with the VA. We have to be communicating with them consistently, and just kind of proving that we are up to their standards of care. So it's really education based, and it all goes towards the hospice and their staff members and being able to provide the care.
It's only for VA or general?
So the We Honor Veterans program is level 1, 2, 3, 4, and 5. So it's just specific to them.
General public, they're all gonna die.
Right, no, we still provide care to the general public at a high level of care. But specifically for veterans, we have the We Honor Veterans program that is rated on those five levels.
So, how do you integrate end-of-life doulas in your program?
So the question is, how do you integrate end-of-life doulas in your programs? Repeating for the Zoom.
We actually have 2 of our social workers who are certified as death doulas, but we welcome that if that's something that the family has selected outside of our agency. We, encourage that, because just like, when you're laboring to have your child, any extra layer of support that you have is just going to make things so much easier for the individual and their family. So at any point, if families request that, even if it's outside of the 2 social workers that I have that are certified, absolutely. The more people that we can have engaged in that individual's care, I think it results in a better outcome.
But one of the challenges to that is that really Medicare does not recognize it or pays for it.
Right.
So the death doulas have to kind of navigate their role and what they can provide. And so legally, it's not really recommended as part of the hospice care. So I find we have several doulas as volunteers. They're also certified. I support them as a volunteer manager. They come in as volunteers, and we kind of just work with them, encouraging them, and then they can be out there trying to get the advertisement, So I say that I attribute, this is my opinion, that when hospice really came around and hospice became aware, they also provided bereavement and grief, because there wasn't a lot of awareness about bereavement and grief. So hospice brought that, and then churches and communities, senior communities, they started to provide that support. And now they also brought on the We Honor Veterans. They identified veterans as unique. So now we have this death doula is kind of a new thing that we're going to all have to advocate for, because they bring a richness and enrichment for someone who's at the end of their life. And so I'm a supporter of it, but we really can't recommend it on hospice because it's not regulated and it's not part of the hospice care.
Yes, question.
I was just gonna chime in, so I'm from End of Life Hospice, New Mexico.
Oh, yes.
And we do have doulas.
Yes.
So, and we don't charge, because we're a nonprofit organization, so if someone needs a doula, you can call our number, and a lot of our volunteers are doulas.
Yes.
Hospice care is
No
so
charge.
it's so patient-centered that whatever the patient, the family, and caregivers want to include, the
Yeah.
hospices are generally just adding that to the plan of care and working with whatever's best for the patient.
But the challenge is people don't know what a doula is and they don't know what to ask for. So the main thing is we need to help our doulas. And yes, you're right. That's one of the resources that we refer to, but we need to help them to identify their role and help them navigate, because families can't ask for what they don't know.
Yeah. We had a question online about how did the social workers wind up in hospice?
Oh,
Yeah.
that's a good question. Do you want to?
Sure. It was something I knew I was going to do. And so I just embraced that and welcomed it. And I think just being very patient-centered and wanting to enhance that experience for a patient and family.
So were you a social worker in a different field before hospice?
But upon completing graduate school, the first job offer I received was hospice social worker, and I knew that I would be doing it. So I said, no, I wasn't quite ready. Did something else, and then I was ready and started working as a hospice social worker.
Okay.
For myself, so I actually have my bachelor's degree in music therapy. And so I've always wanted to help others. And I always knew the older population was the population I wanted to work with. And then I ended up going into activities in different nursing homes and memory care units. And then I got my first taste of social services when I was a memory care director at one of the facilities, actually in Indiana before I moved here. But after getting that taste of social services, of being able to really help others, get the resources that they need, just providing that emotional support of just like being a listening ear or sounding board. I really wanted to continue that. And so I looked into what social work was after talking to other social workers. And then I came across hospice, and I really loved the whole concept of what hospice services provides to their patients and how I can help them in hospice. So that's how I landed as a social worker at hospice.
Well, speaking of music, so I've had 2 people in my life die this year on hospice, and my dad and my husband. And so my husband was inpatient at Caseman's hospice. My dad was inpatient in a Florida hospice, and I flew there and I was able to be with him the last 2.5 days of his life. My dad loved musicals, big band music. And the first night I was with him, he was pretty restless. And I started singing songs to him. And I'm not a great singer, but it seemed to help. And so I had my iPad and I pulled up Spotify for musicals. And I'm playing, the big hits from the musicals. And one of the nurses came in, and it was a male nurse, and he said, that's too exciting music, you want relaxing music. And I was like, it seemed to be relaxing my dad. What do you think about that incident with music?
That's terrible. I'm sorry. I mean, that's probably not the professional word, but so I did the same thing when my mom was dying in 2016. I'm not technical savvy, but I know how to use my iPhone. And I went to YouTube and I started playing the Spanish Rosary for her. And in her agitation, that really calmed her down. And that's one of the things I tell our volunteers when they go through training. You have to be creative. You figure out who the patient is, play your music, comfort touch, aromatherapy, those kinds of things. So I think that you knew your dad better than anybody else, and you knew what you could provide for him. But providing isn't the word. It's gifting him. It's gifting him of who he was. And there isn't any better other care in hospice than that.
And it's not one size fits all. What works for one person may not work for somebody else. And it's really getting to know that individual. And, I would much rather have 50 family members in a room and they're doing whatever that individual would enjoy the most than to have the opposite of that, which is something that we run into. So to have you give your dad that experience, of his favorite things when he was at that stage is incredible. And that's what everybody should have.
And what you're talking about is managing the symptom. So you were managing the symptom of agitation. I had a cardiac patient who was in severe cardiac pain, and despite the medical interventions the nurse interventions, he did not find resolution until he met on a regular basis with one of our social workers. And he was not able to forgive himself. He had a priest come in every day. He had the nurses bringing him communion, but it wasn't until he had that intense connection with that social worker and they worked out whatever needed to be worked out, that symptom resolved. And he was actually on his dying, an hour before he died, he got out of his bed. He was bedbound, hugged his daughter, said goodbye, I love you, and then he was able to die. And so it's about managing symptoms in whatever way, like you said, being creative, whatever way, whatever discipline or whatever music is what it takes. And we have to be creative.
Yeah, I think it's great. You got, the medical side, the nurses, to help, manage the pain through medications. But, with social work and chaplains, we try our best to provide the holistic approach, right? And so whether it is music, meeting what their lives are, of course, and then advocating on their behalf, and that's prior situation. That is really sad that, they were so gung-ho about saying, no, that's not the kind of music they want to hear. But it's, as a past music therapist, we always have to meet the patient where they are and what their likes are. And so if you're doing that, it's going to be more beneficial for the patient and even the family too.
So I wanted to say one more thing about, adding to the comfort care. The team was described, right? And so with the patient, if you start with a doctor, he has something to teach and something to direct or sign off on. And then you go with the RN and she too, I'm going to give you this medicine. She's educating the caregiver, take it this way. So she has something to instruct and something to bring and also towards the care, right? Social workers, they do the same thing. They have something to come in, teach, and guide and direct. The same with the chaplain. They have something to come in and teach and share. But most patients at the beginning, they say, oh, I don't want to volunteer because they don't know what to do with a volunteer. They think they have to host them. So they want to clean up. They want to have their hair done. But it's not them hosting us because that takes their energy. So it is the volunteer to come in and figure out what brings them comfort, but they're the only non-paid staff member on that team. And so why are they here? Really, you're a volunteer, you're giving your time. And the other thing is that volunteers are usually in the home longer than any other discipline. They might come once a week or once every other week. The volunteer is in there weekly. And so they start hearing things about that patient. Oh, they have a son in prison. Oh, they had a death. Oh, they had whatever else they had. They start trusting that volunteer, and the volunteer can share that with the team, providing that the patient allows them to. But it brings the whole picture of that patient so that all the disciplines can better care for them.
Okay, so there was a question that came in online, but I want to ask my question first. New Mexico is one of the few states that has medical aid in dying, but you have to be on hospice to access it. So what are your hospice's attitudes towards providing when a patient requested medical aid in dying?
So this is a huge passion of High Desert. Here in Albuquerque, we completed our 100th ingestion 2 weeks ago. It's something that on an individual level, I'm passionate about. My grandfather was on our hospice 4 years ago in Las Cruces. He had stage 4 pancreatic cancer. And he went to the Mayo Clinic to get a second opinion, and they gave him palliative chemotherapy. And he flew out on an airplane and came home on an ambulance. And that was the most devastating experience for our entire family. And he was this incredible stoic man and just patriarch of anybody that I ever met. And to see him decompensate and to have to go out the way that he did was really devastating. And I've always felt, this is a wonderful service. And when it was legalized 2 years ago, we didn't hesitate to say, this is what we want to be involved in. These have been my favorite patients to interact with. I do 100% of every intake for anybody who's interested in medical aid and dying. We get a lot of referrals from, obviously the hospitals. It's not really something that's well known that it is legal here in New Mexico, which I wish there was more like press and things like that about it, because it is a really wonderful thing. And the biggest part about it is that it gives somebody choice when all of their choices have been taken away. You get a terminal diagnosis and that's it. That controls your life for the duration that you're on planet Earth. And to give them kind of a way out of that has been really magical. I always encourage people to make it however they want. I referenced the second ingestion that we ever did because she was in an assisted living. She had a beautiful home in Tanawan, and she's like, I don't want to die here. I want to die home. And so her sons flew in from California. They filled her bedroom with candles, with her favorite flowers, with twinkle lights. We had one of our chaplains there play her live music. And she passed away in her bed with her sons on either side of her, and she passed in 8 minutes. And it's that kind of unique experience that just really fills our cup here. Our medical director, Dr. Lisa, is incredible. She's bedside for the majority of our ingestions. We also have our nurse practitioner, Hannah, who's bedside. We always have a nurse and a provider bedside. You said you do have to have a hospice referral in order to, come through that program with us. You do have to have a terminal diagnosis. We've seen cancer patients, cardiac patients, patients with ALS. There's, it's just a really kind of unique thing because these patients have made this finite choice and they're so at peace with it. And they get the opportunity that so many people miss out on. Nobody's flight gets delayed and they don't make it in time.
Well, and an important point, part of that is they need to be able to self-ingest the
Yes.
medication.
Yeah. So whether it's a rectal administration or an oral, we adhere to the gold standard as far as deciphering which one is more appropriate for each patient. We work closely with the MAID Foundation. I always mess it up, but I think it's the American Clinicians Academy for Medical Aid and Dying. And then we work with End of Life Options as well. We have our branch in Las Cruces participates as well. Our census, due to the population down there, is much smaller. So we've done about probably 20 ingestions in Las Cruces, but it 100% has to be self-administered. We do a lot of work beforehand, making sure that this is exactly what the patient wants. If there's family conflict that they're not quite on board, that's when I call in my social workers, my chaplains, and get everybody on the same team to make sure that this patient can go out the way that they want to and be surrounded with whoever they want to have there.
What are the education requirements to get to where you are?
And did you have to go to college? Did you need a bachelor's, master's?
College, bachelor's, master's?
So I'm a nurse and I went to UNM, so I got a bachelor's degree. And it's called the BSN, Bachelor Nurse RN.
Thank you.
Mhm.
And for social work, it does require a master's of social work.
I'm a BSN RN as well.
Cool. Do any other hospices want to talk about medical aid and dying? Sure.
So we do not have a physician that prescribes the medication. However, we do support any patient on hospice services who wants to participate in that. Typically, the patients that we have supported are getting prescriptions through a physician out of UNM. And she works very closely with our social workers. She has a wonderful relationship. We just keep in touch with her, support the family as much as they need us to. And we're just kind of in the background, just providing all the standard hospice care and support. However, we're not permitted to do the prescribing, that kind of stuff.
And Presbyterian is very similar to your practice. And each nurse and patient have the conversation of whether or not who they want there. And so I'd probably say 90% of the time is probably like your business is that they want their nurse there, you know, just because they've been taking care of them. So,
Okay. Our time is running out.
There's a question back there.
Yes, last question.
Last question. What is the attitude in general of the patients, knowing they have 6 months? Or the some don't even have an attitude because they're so ill that they don't have it?
I'd like to answer that.
Okay, what is the patient's general
Yes.
attitude? Of
So-
course, it's always different.
I have a lot of experience with going into the homes. I'm not a nurse, but going into the homes when they're asking for what is hospice and what is the benefit. And sometimes the families are there, sometimes it's just the patient or their partner or spouse. But I tend to tell them, well, of course, I tell them what hospice is, but if you ask a person who is terminally ill and who has been under tons of treatments and have been everywhere, maybe benefiting at first, and then it's come back, and then they go back to being sick, I have looked at them and asked them, do you believe that your condition could take your life in 6 months? And they always say yes, with a kind of a relief. But if there's family members there, it allows them, gives permission to talk about that. Because I find that most people know that they're at the end of their life. They just need somebody to be honest with them and let them know and affirm, because they know better. And even when families say, don't say the H word, you know, grandma, mom, dad, they know it's the denial of the family.
and you know, I just want to say something. I said each and every one of us up here, I call pioneers, because we're all, and I believe this, they're all brave enough to go to the patient and answer their questions honestly, respectfully, figure out where exactly they are and not to be afraid. And so, you know, you have this warm, beautiful hospice heart person that's pouring themselves out to the patient and asking the patient in response to allow them into this very private time in their life and gently walk them through their journey. So I think everybody up here gets that, has that particular heart.
I don't know anybody who works in hospice who doesn't know with 100% certainty that this is what they want to do with their life.
Yeah.
I just wanted to add that typically the feedback that we receive is, I wish I would have called you guys sooner. I wish we started on earlier.
Yes.
And that's generally what we hear. And it's so sad because we want to be there. It's just so, the hospice word is just so, there's a stigma around it, and we just have to get away from that.
And you know, it's not just with people, common people like us here. It's the professionals that won't have that conversation with someone to say, you know, at this time, your body is not benefiting from treatment. So maybe you need to have a conversation with the palliative team or hospice. And so we sometimes, a lot of times, get them, you know, a few days before they die. And it's not enough time to really give them that end of life journey. So we have to educate the physicians and, you know, specialists, because they won't refer either.
Yeah, our liaisons do a lot of work out in the community on when a patient is appropriate for hospice and not waiting till the last minute, because you're just robbing them of that experience.
Yes.
Well, thank you all for a wonderful, enlightening session.